Bonjour. Good morning, everybody. So, dear François, I have lots of questions for you. I hope I have the answers. You've given yourself 3 priorities: to fight against inequalities in health, to give health practitioners all the tools they need for their action, and to decompartmentalize the healthcare system. That's a hell of a job. What are the concrete actions do you intend to take to launch the profound change of our healthcare system to adapt it to the 21st century? I think the most important thing in our current healthcare system and its difficulties is to be able to release the energy in the field, in the grassroots level. That's the reason why we have this Council for Refoundation of the healthcare system next Monday. I won't be able to do it by myself. I'll only succeed with all the help of the healthcare professionals, with our citizens and elected representatives. We have 2 main areas of action at the moment. The first area of action is to meet the difficulties of our citizens. So that's to find the relevant ideas in the field and to put into application and set up the toolkit that we've already set up this summer. And these concrete actions will be focused around the GP for those people who don't have them. It will be to provide continuous treatment for people who need to find a healthcare practitioner, to increase the attractiveness of the healthcare system, and also to carry out prevention, because everybody knows that I am the Minister of Health and Prevention. These 4 points if you're talking about figure skating, it's the imposed figures in figure skating. So at the level of the territory, this will be applied everywhere. I'll need all of you in each area of France to be able to carry this out with the prefects and the regional health directors and the politicians and citizens, and there will be subjects which will be free figures. In other words, according to the issues in a certain territory, there will be specific problems to be tackled, such as, for example, in the Moselle, there are transborder issues. These current issues, these concerns of our citizens who find it difficult to find a doctor, we need to find immediate answers for them, and I will build those responses with the territories. That is why we have this territorial Council for Refoundation of the healthcare system. There are other cross-disciplinary and cross-functional issues, such in general medicine, issues to do with simplification, where we need to have a debate, but there's no justification for a territorial approach to that. So there will be a more of a national approach there. Will the components, the politicians, healthcare professionals and citizens, and these are the immediate actions, a territorial consultation. And the debate will take place throughout the country up to the end of the year, and then we'll have the transverse points we will be presenting at the meeting on Monday, where we start our Refoundation Council. This will be up to the first quarter of 2023. We will move quickly because there are immediate needs. This Refoundation Council isn't just to describe the problems. It will be the aim is to take action. It will be to implement solutions, and we will talk about how we do this, how we implement these measures, and then we have to look to the future of our healthcare system, with this demographic transformation, not only in terms of the population, also in terms of the healthcare professionals. Today, we are incapable of knowing how many doctors, nurses, and pharmacists we will need in 2030 or 2050. So we have to look much further ahead. It's not easy. It's not just the age pyramid, it's also the changes in pathologies and changes in treatment, and the transfer of tasks between different healthcare professionals. So we're starting to work on that as well. We're also starting to work on the ecological transition of the healthcare system with emerging risks. You've seen that we've created the COVAS. This is a new scientific committee headed by Brigitte Autran, whose responsibility will be to look at One Health, to look at the zoonoses and other pandemics, etc., that may occur in the next 10 years or 15 years. Then we mustn't forget the issue of governance of our healthcare system. There is a lot of things to do in terms of governance. There are no taboo subjects. Everything will be on the table, including the reform of our ministry. And finally, This whole rationale must be also taking account of financial sustainability. This is something that we need to consider with all of the healthcare professionals and all of the stakeholders. Have a new system for funding this healthcare system to make sure it's relevant. And so there's plenty of work to do. I'm sure we'll have many things to do with immediate action straight away, because French people are expecting it and they need it. We have looking to an immediate term to next year, and also in the longer term for development and change of our healthcare system. Thank you. I'm thinking again of the medical studies. We're completely crazy in a world where we can use digital technology to simulate. We're talking about 10 years of studies or 14 years of studies for a specialist. It's crazy. It takes 14 years to train a surgeon today. Whereas robots are being used, we are moving towards a prolongation, even longer studies. Nobody understands that when we have all these new digital solutions. Everything is done to reduce the time that is required to train these people. They can train while they're in service. There are two questions there. There's a question of simulation in healthcare and the question of studies. Well, they go together. Well, not only. If we take this question of the duration of studies, the fourth year of general medicine, this is something that is demanded by the interns, and because they need that training. For example, management of a surgery, for example, for a GP. Then it's true that simulation contributes a tremendous amount. It reminds me of a very personal episode I had with a friend, an anaesthetist who went to Canada about 20 years ago. He was in Gaspésie area of Canada. He was rather isolated. He was a bit of an original character. He enjoyed canoeing and kayaking. And one evening, I was in a farm with him. We were talking about the difference between North American medicine and French medicine system, healthcare system. He said, here I have discovered a medicine which is science, but for us it's a science and an art. Why do I say that? It's great if we're going to save time in the studies, but if we put a bit more humanity in the studies, if we bit more humanism in healthcare, and learn to talk to patients. We're talking about the end of life, help people through the end of life. This is something we need to do, as well as the technical side. Of course, simulation helps us to overcome these technical issues, perhaps more quickly. I'm not certain, but perhaps more quickly. Yes, why not use that? But also, let's add some more humanism in our studies. I absolutely agree with you. I'm sorry to see that apart from a few faculties, they are doing this, but in fact, there ought to be an actor pretending to be a patient so that interns can practice. Today they're just looking at computers to say, okay, they're looking at the computer screen, then they're looking at their patient, they have their headsets on, there's no longer any human relation there. This is terrible, and this is why we're having an explosion in alternative medicine. What are you going to do? I saw that at Pellieu, you've worked in A&E, the team with the Tournon, I think, they've set up a mini rapid response unit to be able to provide unscheduled care in an emergency without any physician being involved. That's the future, I think. It's the future. It's one of our possibilities that we have. Yesterday I was at Le Mans. We have started the Refoundation Council already, and in fact this idea came from Le Mans because in the Sarthe area there was only one rapid response unit left, and they couldn't find enough doctors, and so they set up the EPMEs, which was teams of A&D doctors with an ambulance driver, and which are a precursor of the rapid response units. We did the same thing with the mountain doctors, as we're in a country with a lot of mountains. That's a first response. The results are very good in that area. We gain about 20 minutes for the arrival of the rapid response unit. So that's quite something. We need to develop that more. You're absolutely right. I could talk about it for hours, but we remain blocked in a very old-fashioned approach where you have the rescuer and the resuscitator, which in English-speaking countries, they are ahead of us, and now everybody's moving towards the same situation. You have the resuscitator and the ambulance driver, and then the A&E behind that. Another important thing when talking about emergency services, which was created in the Manche area at Saint-Lô, which has been developed. These are teams sent by the emergency ambulance with a nurse and an ambulance driver, and also a telemedicine unit. There again, the results are remarkable. With 2,000 patients who would have been taken to the hospital because there was no other solution, by sending in this team with a telemedicine capacity, 2/3 of people stay at home. So we can see that by making use of other healthcare professionals, and we need to work with other HCPs and broaden their areas of competence and go further than the cooperation protocols, and also by advancing in technical sense, we're going to be able to reform our system and make sure the doctors are able to stay where they are able to best added value to patients. So we could almost say that eventually, maybe first of all, people go and see a nurse rather than a doctor. They should systematically perhaps be seen by a nurse, even if the nurses would require additional training. This would be able to resolve 40 or 50% of problems. Couldn't we look at that possibility and keep the GP as the next level, the level above that? For example, nurses could provide many different, with an advanced training, they could perhaps provide many services that doctors carry out. We don't want to throw out the baby with the bathwater. Of course, there is a position for advanced trained nurses with advanced training and our healthcare systems and in our treatment pathways. But you do need to have a doctor to carry out a clinical examination. That it is necessary. How do we sort this out and allocate the tasks? This is being sorted out at the moment with the many experiments starting with training of advanced training for nurses. This was approved already last year, so we're going to test this out on a number of different cases. We've had a broadening experimentally of prescriptions being provided by the pharmacist, and also for getting direct access to a physio without having to go through a doctor. If we want to secure and protect the system, there's something called medical regulation, which is very good, which means that when you have several, if an HCP has several areas of competence, then you can orient the patient to the most appropriate HCP who is best placed to look after that pathology or that problem. I can see what you're saying. The question basically is, okay, where do you put the doctor? If you don't completely redesign the organization of HCPs, what position, what role they play, we're going to carry on having too many, we're going to have doctors who are giving prescriptions and carrying out many repetitive tasks. And I agree with you. The beginning of September, as part of the CLIO, which is the committee which links together HCPs, I said to them, you are responsible. You are going to define the professional framework. You have to agree on the transfer of tasks and areas of competence. I'm waiting for them to get back to me, maybe today or tomorrow. I met them at the beginning of last month. What I said to the order of doctors is that the doctors are going to be the coordinator. All the HCPs have to be included. We cannot imagine that the doctor does everything. That's not possible. If we want to solve the problems I mentioned, in other words, be able to have a GP for everybody, we can see what you call assisted work. You need to have a medical assistant who can take 10% more patients. At the moment, this is restricted in a lot of areas. And this has to be stopped. We have to share with the advanced training, nurses with advanced training, other HCPs, and others, such as even dentists as well. We're changing all of this. It's a great orchestra, but we have to have a conductor for the orchestra. The conductor will be the GP. I think that's perfectly logical. Today, when we look at the GPs, they very few GPs go to a school or a company. They only go, or into office. The only people who are familiar with the entire environment are the nurses. The GPs just remain in their surgery all the time. And nurses are going to companies, to schools, and they know their environment much better. I really think the role of the nurses should be increased. They want to. All of them, not all of them will accept it. They don't want the additional responsibility. What I'm saying is they should be delegated to do something. They have to true responsibility. This is the case of the IPAs, the nurses with advanced training. I don't absolutely agree that the GPs don't go outside, they go out in the community. Maybe less than before, but they do visit outside in the community when they can. But the advanced nurses with advanced training are an important solution. We have 800 of these IPAs, 700 in training at the moment. It's very much focused on chronic pathologies at the moment, but I'm sure that with the HCPs, we can think about other extensions for other responsibilities for IPAs. In schools, in occupational medicine as well. Yes, so they could work more with children as well. In nursing homes, they could work with in the geriatric area as well. I won't be by myself. I won't be able to succeed by myself. I have to work with the HCPs. This also means, as I was saying, tomorrow the GP will look after those who remain. I don't think they need to work more. I think you need to train more doctors. Today you need 1.8 young doctors to replace one of the from the previous generation, because they work less hours, but you don't need more doctors overall if you have the other personnel taking on more responsibilities. I agree on the conclusion, but not necessarily on this young criticism of the young generations who say you want to work less hours. Our young colleagues work in a different way. I'm not accusing them. Maybe they're right. They take charge of a number of patients, which is very high. They want to do work in a different way. They don't want to do administration. They want to do medicine. And that's true, and they're right. And that's true in the hospital and in the community. We need to get rid of the red tape and the bureaucracy and let other people do that, or just eliminate this red tape and bureaucracy when possible, to get rid of the administrative tasks whenever they're possible and not useful and unnecessary. So that means that tomorrow, very quickly, the GP, as we knew him before, will become the GP in the old form. In other words, working with the elderly. Perhaps they could be working in medical oncologist as well. We're no longer to see the GP as we've seen him as we've seen this in the past. Except when you use AI, if you go to India, you can put your symptoms in the systems of these platforms on internet. Isn't this the future? Of course, you have to examine people. You have to look at an abdominal examination. How often does that happen, actually? You don't examine every patient. That's not the case. Yes, the day before yesterday, I was at Le Mans to prepare for this Refoundation Council. I was talking to the first working group, who are going to look at the continuity of service and other activities as well. And this working group said, what we need is this kind of tool for minor symptoms. What we need to have is the grandmother we had before, who we said we could call up and say, my kid is 3 months old. Why is his face gone all red, for example? We need this kind of tool to replace the grandmothers. I don't want to get rid of the GPs. I don't want to lose them. Even the way they work. My father was a GP. It was a great thing to be able to do pediatrics, geriatrics, look at all the different pathologies. There's something which surprises me, which is that we have major difficulties with pediatricians. It's very difficult to find pediatricians in many areas. A GP can do that kind of work as well. I think a GP should be able to do that kind of work as well. We need to be more reasonable. They will have more time because they will have less administrative tasks. They will be able to do other things, have a broader remit. Another subject which is causing waves is the President of the Republic has launched All France, and is the people from pharmaceutical industry who are investing huge amounts of money, especially Sanofi. And at the same time, they say to the pharmaceutical industry, we're going to lower your prices because you've earned too much money. When in France are we getting out of this Malthusian approach, saying, because we've made lots of money, we've been successful, we have to punish ourselves? I'm not a pharmacist myself. I'm a physician. I don't understand. Whenever anybody succeeds, they bang them on the head and say, you've made too much money, and that has to stop. Isn't that what it's like? Well, you're exaggerating a little bit, I think. It's the same with the biologists. They've worked, done very good work during the pandemic. They did 120 million tests. They took on extra people, and they worked on the Sunday. And now we're saying, okay, we're going to bring your prices down. Maybe we should say to them, you should have more, put less money for the shareholders and more for investment. But saying that you're going to bring down the prices, for me, it seems like you're punishing them. You're oversimplifying, I think. I can understand why. Understand your concern and the concern of these sectors. Everybody, in a way, all of us have to contribute to this effort. The sustainability of our healthcare system is absolutely vital. We're always saying things, we have major problems, but the healthcare system in France is an extraordinary thing. We're able to treat everybody, regardless of their income and regardless of their social status, and this is a fantastic tool. And we all pay for the social security system. Everybody has to participate and contribute in different ways. It has to be done in a coordinated way. Coordination is very important. And we have to, this effort has to be coordinated with the biologists, or pharmaceutical systems. Somebody told, the President of the Republic said, we're on the crest of a wave. We have to support innovation. So we're looking to 2030, 7 billion euros have been invested in that area. All staff facilitate access to innovative products. The ministerial order is being drawn up with the HCPs to get access to and facilitate access to these products. Another example, you've seen that the Health Insurance Agency has done an investigation with our neighbours on the use of innovative products, taking 12 innovative molecules. People always say France is behind it. We are the second of those countries. We have many innovative molecules that are being developed in France. And then, yes, for more mature companies, we have to support them. They have to be able to remain and provide drugs, and we have to attract others as well. And in another way, we also have to participate to the war effort. We're setting objectives. That is my role, the role of the government, to set the heading. And then as to how we achieve those, whether it's with the pharmaceutical industries and biologists, we'll talk to them together and see how we do it, but the objectives are clear. Okay. And finally, I don't want to keep you for too long. Are you confident that this Refoundation Council is not going to become bogged down with endless PowerPoint meetings? With it becoming a PowerPoint competition? Well, you should have been with me yesterday. They had 100 people, 11 working groups. I hardly had time to say hello to them. They were busy at work. Then they gave me feedback on the work they were doing. It was remarkable. If we're able to do this in all of the territories, let me say we're focused on action. We're not, people aren't complaining, saying we don't have any doctors. We know about these problems. The fact that we bring in the politicians, this is the first time. They all said to me, this is the first time we've had this setup. Politicians, HCPs, and citizens. And together, they are finding solutions. If you multiply this, I don't know, the President of the Republic said to me, 1,200 territories are going to be involved. Maybe not in the next 3 months. I was asking a bit much. Maybe if we have 200 or 250 territories in the different areas, and including the overseas territories, I really do think that it's the first time this has been done. First time, I saw it yesterday in Le Mans, and I'm very optimistic. For those of you who will be there on Monday, I hope you all will be. We will give you a presentation not only of the method, we'll also give you the first results. We will have 2 roundtables, one on attractiveness and another one on the role of the politicians. We're choosing different subjects. We have guarantors, one of whom is in the room here today, to make sure that all of this work is ethically sound. We want humanism to be brought back into the care professions. We have a lot of momentum. I think it's going to last 3 months. We have to work quickly, and the results that will come out, even if they come out gradually, it's a bit like the flash mission on the emergency services. It works, we evaluate, it's relevant, and then we keep it. And we'll draft the legislation as it goes along. The big change I want to create here is not the administrative framework that is the most important thing. If you have an initiative, you don't have to fit it into the existing framework. If it doesn't fit in, we say, no, if it doesn't fit the administrative framework, we're not going to do it. No, that's finished now. The administrative side has to adapt to innovation. So what will be done at Brest won't be the same as in Strasbourg or in Lille, in Marseille, because we've done lots of experiments, and when we try and apply them everywhere, nothing happens. It won't be the same in each region, because the issues are different in each region. The pathologies in the east of Moselle, in a former mining area, not the same as in Chamonix or in the southeast of France. So this is my concept of the toolkit, and it's worked very well this summer. You'll see the results very quickly. We have reduced the number of people going into A&E. We didn't have any dramatic incidents, as everybody said was going to happen. The toolkit is something that everybody can use. I'm sure you have a toolkit at home. You have a flat screwdriver and a cruciform screwdriver. Depending on which sort of screw you want to work on, then you use a different screwdriver. For us, it's going to be the same. So are we going to have a regionalization of all the money, the amount spent on each patient? Are the regions going to be able to use some of that money? Are the regions going to have more responsibility? For example, today it's difficult for a president of a region to say, we're going to close down this maternity and we're going to spend the money on something else. Are we going to say to the regions, you do what you like, you can decide, we have the major causes such as cancer and Alzheimer, and the other rest you can do what you like? No, that's not how it's going to work. I have to tell you what's going to happen. We're going to work more with the local authorities, whether they're regional or intermunicipal. That's why the refoundation Council is very important. However, I'm not favourable to regionalisation of a healthcare system, because I saw during the pandemic with our German, Italian, Spanish colleagues, when we explained to them that we were transferring patients from one end of France to another, and they said, in our country, that's not possible. The regions don't work together. And in France, the regions work very well together. The other point is that I don't want everybody to get treated on the Riviera because it's a richer region and people think they're going to get better treatment. Healthcare is the central government's responsibility. It's a state, it's a government responsibility, and the government is the principle of that doctrine, strategy, and tactics. Doctrine is a principle, strategy, how do we develop the doctrine, and tactic is implemented by people in the field. The state is there, the government is there to give the doctrine. The strategy will be defined on the regional level, and the tactics will be implemented on a local level. So we define the doctrine for healthcare. Thank you very much, Minister. Thank you very much indeed.